Hello. Welcome to another episode of Daily Wisdom Words Podcast. I am your co-host, Rini O'Day.
Hey everyone, I am Neil Trivedi and I'm also your co-host. We want to thank you for joining us today and give you a very warm welcome to our latest episode.
Come join us every Saturday at 9 a.m. Pacific time as we talk to guests who have stories, advice, life hacks, all of which take you one step closer to hope.
Today, we're so proud and honored to welcome back one of the most renowned addiction specialists in Colorado, Dr. Andreas Edrich. Welcome back, Dr. Edrich.
Hi,
Appreciate it.
Dr.
Thanks,
Edrich.
guys.
How are
Thanks,
you?
guys.
Nick,
I don't know
did you
about the
see
most renowned. There's so few of us. It
Wow.
doesn't take much, okay?
Listen, in our opinion, you are
Wow.
totally renowned.
Yeah.
I don't know if that gets you in line faster at the grocery store, or maybe an extra Big Mac at McDonald's.
Right. Don't need
But
to
here we
feed
are.
my fast food addiction.
Right.
I've stopped it. I've stopped it. Stopped it dead
Nice.
completely. No more.
Nice.
No. Yeah.
Yeah.
If it's coming out of paper, I'm not eating it.
Right.
Right.
It's got to come from Whole
Right.
Foods.
Yeah.
Trying to anyway.
So,
Some days
Of
it's hard.
course.
so last time you provided us with such fascinating information on addiction, and this time we thought we'd talk about some of the aftermath of, after people become addicts and all that. And also we thought we'd touch on a couple other issues, that stem from severe trauma as well, things like DID that I know you've dealt with as well. So
Yeah.
I guess last time you had said that you brought up a very good point about people going to rehab, addicts coming out of rehab, and then often relapsing, right? So
Right.
if rehab doesn't prove effective, are there alternative options to treatment and stuff? Or is it more of just
Yeah.
finding the right kind of rehab or finding the right kind of therapy if the first 2-3
That's
times
a
it
good
doesn't
question. That's a good
That's
question.
Rini, by the way. Rini thought of that
Right?
one. So
Awesome. I'll give
I'm
you
just
credit
saying
for that one.
Thank
It's
you.
an excellent question.
Yes.
It's an excellent
Thank
question.
you.
And let's qualify that first of all. So rehabs can provide a lot of benefit, okay? So it's not that they're ineffective. It's just something happens when people get discharged that they frequently relapse. And then we have to say, is it because rehab isn't effective, or is it because when they get discharged, they don't have the proper follow-up, or the underlying issues weren't really addressed? Could be any number of those possibilities, What they do at rehab while they're in rehab is oftentimes phenomenal. Coping skills, counseling, group therapy, support network, collaboration, just a lockdown scenario where there's no access to the outside world, no cell phones, no contact with dealers. All that stuff helps to control the person.
Mhm.
But then what happens when you blow out? Why is it that people, when they leave jail, relapse in 2 seconds,
Right.
They probably do better coming out of a rehab because it is a therapeutic environment, but they do a lot of rehab work in prison too, But the problem is that most of the time, here's the frank truth, they don't have the support network. It comes down to family and support, and they don't have the professional network, and they're not plugged in ahead of time. And so when they leave this ultra supportive environment and they're out on their own. It's kind of like sending a teenager out of the house before they're really ready, like they don't have the outside tools. They haven't practiced using the outside tools yet. They should almost be graduated slowly from rehab, not discharged, but gradually released, where, hey, you get to spend 1 or 2 days at home. The rest of the time you come back to rehab. And then a week later, you spend 3 days at home, and you're back in rehab, and then you show what you're doing on the outside to increase your tools and how you're using your tools, and where's your doctors, who have you followed up with? I think that's the biggest problem. And when my patients go in, it's an absolute struggle for me. And I'm in the network, I'm in the system, I know these people, I call the rehabs, and It's difficult for me to get a clear answer when I say, hey, I want to know when they're going to be discharged, or approximately. I want you to touch base with me a day or two beforehand. Call me. Let's set up an appointment time so that, like, within 24 hours after discharge, I've got them on in front of my face. Or better yet, let's maybe do a video chat the last day or 2 days before they discharge. Let's get something teed up. Even that's complicated for me. And if it's a regular doc, they don't have time for that. They're not doing that. They're not communicating. They'll wait for the patient to call, make an appointment, and then 2 weeks later we'll see you. And like, that's not. And that's the problem when you said I'm the most renowned, but when there's only one of us, right? That's not much of a compliment, right?
Yes, but you are renowned. I mean, people really do know you in Denver. They do.
Yeah. Hence,
I love it.
Busy schedule.
Yeah, it is busy. It is busy. And the problem is that, who do these people go to? Right now I'm talking to another live-in rehab group here, and my whole point talking to them will be, how do we prep patients? How do we get them in front of me? But what if I'm full? And what if these are patients that don't know me and they live across town somewhere else and or in a different part of the state? How do we get them in front of us and treated? Do I stay a small practice like I am, or do I add 3 or 4 doctors and become this mega monster machine, which then it removes the personal touch, obviously, or how do we convince other doctors to do this? I just had a medical student for the last 2 months with me who's really interested in psychiatry, and now that she got a taste of addiction medicine, psychiatry, and even family medicine, because it's important to not drop patients through the crack on any front, So if I have them for their depression, then it's a great in for me to try to evaluate if there's any addictions. If I have them there for addictions, it's a great inlet to talk about, hey, what else is going on in your life,
Doc, are there medications to curb addiction?
There are. Okay, those are after everything we do, basically, which is kind of sad in this country, is retrospectively. It's after the fact. We have a lot of heart medications that we start after the heart disease. We have a lot of blood pressure medications after the blood pressure started going up. We have a lot of diabetes medications after diabetes has been diagnosed. The preventive world, what you're asking for is, are there any vaccines for addiction?
Yeah.
I think that's
that
what
would be fantastic. Wouldn't that be
how cool would that
the greatest
be?
thing in the world?
Actually, they did come up with a vaccine for one addiction.
Oh, let me guess.
Right.
And the pharmaceutical companies didn't release it. But what's the addiction, Doc?
It was cocaine. It was a cocaine vaccine.
Oh, I remember you telling us about that.
Yeah. So they built a vaccine. Yeah, they built a vaccine so the antibodies latch onto cocaine, and the cocaine doesn't go to your brain, so you don't get that high.
But then they start doing more.
Well, they did more, and then the cocaine, even though it couldn't go to the brain, couldn't cross the brain barrier, it still could go to the heart. And they were dying of heart attacks, because they kept trying to use more and more and more. So, but the principle is still, is there something we can do preventively? And that's always the name of the game. Look at cervical cancer in women. We have a vaccine against the virus that produces all cervical. How many cancers, seriously, how many cancers do we cure? Like 0, And now we have a vaccine against human papilloma virus that causes all cervical cancer, Like, that's pretty incredible. It's pretty incredible. But the preventive part, the medications that we use, do help with curbing stuff. So when we talk about alcohol dependency, there's naltrexone and Camprol that can help reduce the craving for alcohol. Or when you use alcohol, you don't get that relaxation, so you don't get that benefit anymore, Or when you use opiates, we have opiate blockers, It's very limited though. So like when we talk about marijuana, for example, there's some medications that can help reduce like the withdrawal effects from stopping marijuana. But see, I'm always talking about after the fact, right?
You can get withdrawals from marijuana?
100,000 billion%. And I've got 18-year-olds
I
calling
didn't
me
know
going,
that.
Doc, you got to help me come off this stuff. It's running my life. I can't stop. Marijuana, they talk about being like 10% addictive or whatever. That's for a 40-year-old. That's the little snag that didn't tell you.
Right.
For teenagers, it's up to 50% addictive, 40, 50%. So it's very, very strong. And when you stop, you get rebound, you get recurrence of the exact things that you tried to use it for initially. So marijuana initially calms you down. The rebound is anxiety, helps you go to sleep, but the rebound, the withdrawal is insomnia, you know? And so then eventually you get side effects from both ends. You get side effects from needing higher and higher doses of weed, like psychosis and even schizophrenia, right? And then you get side effects from coming off of it. So then you're jammed in between the zone. It's not really helping you because you're getting paranoia from using too much. And now you're getting withdrawals from not using enough. You're like that's what the opiates are like too. In fact, that's what a lot of addictions are like. You can't drink more alcohol because then you start becoming impaired, but you have such a high tolerance that if you drink less, you start going through alcohol withdrawals. You can't use more opiates because you start, dying. And you can't use less because you go through withdrawals. So opiate addiction patients, they live in this little world where they will tell me, they'll say, Doc, I haven't gotten high on heroin for years now. I only use it to stop getting sick anymore. Like that's all they use it for, is to get out of withdrawals. Like there's no benefit anymore once you have that high of a tolerance. And that's a bad spot to be jammed up against,
So what do you do with people like that? What do you do with the guy that's been using heroin for 10 years, no longer getting high, and he just wants to come off it?
There's only two options because everything else doesn't work. I'm going to wean myself off heroin. Never works. Like 1 billion dead people have proven that system doesn't work. Basically, we sidestep from an opiate that we cannot control, heroin, fentanyl, very short-acting opiates that go in and out of your system, in and out, fentanyl, right? So those opiates are right, and that's what everybody's using. But the reason it's so addictive is it goes in your system really quickly and it washes out of your system really quickly. And that constant in and out in your reward system in your brain reinforces the addiction, and it increases tolerance, which means, hey, one fentanyl pill used to do it, but now it takes 2. A week or 2 later, it takes 3, and now it takes 5, and now it takes 10. And eventually
10,
you're
dead,
die,
right? 10, you're dead.
No, I have people taking 50 or 100 pills a day, and they're about that close to being dead.
Right.
And the problem is that once you build such an enormous tolerance, you can't do less because you get withdrawals. You can't do more because you're dead. Essentially, the only thing we can do is sidestep to a very, very, very long-acting opiate to lock those same receptors down. So we sidestep from heroin, fentanyl to methadone or Suboxone. Either one, they both work. One isn't better than another. They're different. And so we sidestep. The Suboxone locks onto the brain much, much tighter than fentanyl or heroin ever does, and it doesn't let go. And so it basically produces that little cast around the brain so that all the opioid receptors are locked and there's nothing coming or going and coming and going. And so the brain doesn't feel withdrawals all the time, and it's locked down. And then you give it time, like a year or so, with the same dose to allow the brain to start healing and reducing tolerance. And then we can start weaning down the Suboxone or the methadone,
The brain is amazing. Amazing.
It is amazing. But remember, younger diseases tend to be more permanent. And this kind of goes into, Neil, your other question about DID. The younger a person is with a disease, right, the more permanent it is, right? We all know that. This is not new. Right. The younger diabetics tend to, guess what? They're on insulin for life. Like, how many 10-year-old diabetics do you see that come off insulin, right? Like, that's not happening, Right. If we get diabetes at age 40 or 50, hey, a lot more options out there, lose the weight, exercise more, eat better, reduce your, maybe just some pills. And so the same with addiction. The earlier you are, especially below the age of 25, it seems like that's kind of kind of a block in the developmental part where full development occurs by around 25. People think it's 18 or 20, but it's not. Of course, it's older, and of course, some people it's much longer than that. But the developmental piece is around 25, and if you use below that, it becomes a lot more permanent. And it's hard because a lot of patients with addictions are like, well, when can I come off this stuff? When can I go on it, and when can I come off it? That's their second question. You know?
Neil, I'm gonna ask Doc. I'm gonna tell Doc something real quick before you ask your next question. I'm so sorry, Doc. I hate to tell you this, and I'm sure you have children, but at least 50% of kids in high school are smoking weed, and they're smoking a very high THC.
Right, oils, shatter, wax.
I didn't even know what wax was until I started, researching.
Yeah, look up shatter.
Oh, shatter. Okay.
So I've got two 20-year-olds now that are both schizophrenic from weed.
Wow.
At least we have no other reason why. There's no family history. There's no previous. They were like, one was valedictorian. Now he's staring at the wall drooling, and that's his life is over. And his mom asked me if he should stop smoking weed. I'm like, whatever. Game over now,
Yeah.
He'll be instituted. Yes, I'd like you to stop, but
he can't get better from that. Schizophrenia.
No, that's that'll be permanent. You can control it to a certain degree, but it requires a high amount of social support, medication support, and it produces immense life comorbidities, And that's the sad part is, when I ask all my heroin addicts, literally 99.9% of them, when did they start with whatever 100 years ago? Their answer is always marijuana. And when I ask them how old they were, it's 99.99999. Is that enough nines? Percent age 13.
Yeah.
So if they're starting at age 13, that puts them where? Middle school, right?
Yeah. I didn't even have my first cup of coffee till I was 25.
Right.
I didn't.
But
I was a good girl.
That's the problem, right? Is we are not, again, talking about prevention. My big idea would be, aside from me becoming president, I think that'd be a good idea.
I'm voting for him. Are we voting for him now? We're voting for you.
Yes.
There you go. My big push would be right. Why can't we spend some money? Why can't we spend the taxpayer money that we're wasting on drug enforcement and rehab and Medicaid? Why can't we spend some of that money and buy us a whole ton of therapists and stick them all over the middle schools? And every student has an assigned therapist starting at whatever, obviously before 13 years old. So maybe starting at age 10 or 12, why can't we spend that money? Because I'm sure if you put 5 psychologists in every single middle school in this country, that would probably be cheaper than all the people that we're locking up in jail. And then your and my money has to, we pay for that, right? It's not like it's free, right?
Yeah.
Our taxes pay for that. Why can't we use some of that money and actually do that? Right?
In the school district that my children were in, because they're all graduating now, I have a girlfriend who's a teacher. They just started putting 2 psychologists in every middle school.
Oh, that's a wonderful start.
Yeah.
But it should be 10 psychologists in every middle school.
I know.
Every psychologist, there should be every room should have a teacher and a psychologist sitting in it, essentially. Yeah, and if you had that, I'll bet you that would still be a lot cheaper than what I'm doing. Okay. Like the work I do, and when you look at other diseases and things that, because people always ask, what comes first? Does the addiction come first, or does the mental health disorder come first?
Mental health.
It's pretty much always the mental health. And so same with things like DID, where people say, well, how does dissociative identity disorder fit in with addiction? It's the start, man. Almost 70 to 100% of DID starts with sexual abuse or physical abuse before the age of 6. This is not an adult disease.
I'm sorry to interrupt you. Because you brought it up and we were going to talk about DID, can you explain exactly what that is for our audience, for those who don't know? And is it anything like it is shown in the movies? That's always fascinating to me. The portrayal of it in media.
Right. No, it's essentially a disruption. First of all, it begins with a severe trauma, almost always, okay? And it's very common, 70 to 100% before the lower than age 6. Most of the time sexual trauma, sometimes physical trauma. When people get, traumatized later in life, especially as, young adults and adults, then we call it PTSD. It's a different animal, okay? Dissociative is when you have a young, undeveloped child who gets abused, and they create this defense mechanism, right? Not a good one, but it's still a defense mechanism that allows their brain to say, this is a super uncomfortable zone. I'm going to go ahead and step outside of this. I'm going to live in this other world, and it's a discontinuity in your sense of self and a sense of like agency with related alterations in fact, behavior, consciousness, memory, perception, cognition. There's a lot of components to it, There's memory gaps that comes with this. Obviously, the definition of a disorder is it's so severe that it gets in the way of your important things in life. Because I've got patients who dissociate, and maybe they're going through some severe trauma, somebody died or something really happened, and they'll call me. They'll be like, I feel like I'm outside my body. I'm just dissociating. I just feel like I'm floating above my body. I'm not really in it, not present, what's going on. I'm like, that's just your brain's maladaptive way of saying, I don't like where I'm at. I'm going to step outside the room and just stay out there for a while, And when you have a child, they don't know how to do anything differently. It's really, it's a defense mechanism. You can't blame them. You can't stop it. You can't affect it. It's kind of one of the most primordial kind of defense mechanisms there is. When I don't like what's going on, I'm going to step away from the situation. And a child's brain will do that. They'll simply step away, and they'll have dissociative amnesia, where they can't recall stuff. Notably, sometimes the trauma, of course, they can't, right? And you have to be very gentle when you ask them about these things. Pardon me, but the symptoms are broad. Yes, they will sometimes have multiple different personalities, but the personalities will sometimes be like they can be sexual personalities, they can be different genders, they can be different occupations, they can be, like one girl, she kind of gets into the Harry Potter world, like she's read all the books, and that's her defense mechanism. Like, I'm going to go ahead and live in that world now.
Yeah.
Right?
Is it a way of an escape? Like a normal person, like we might watch a movie or a TV show and we say, oh, we live vicariously through our favorite TV show character. So, but they take it one step or two steps further and become those people.
How different is it from what Sybil had? We all know Sybil, the movie Sybil.
Vaguely. I grew up without a TV, so I apologize.
Oh, well, Sybil was a girl that had 27 different personalities, but she was blind and deaf. No, maybe I'm mixing.
No, I don't think she was blind and deaf, but I don't think so. But yeah,
but that was the other one. She had 27 different personalities.
Okay.
Yeah, and that's a good segue, because contrary to what I've read, is contrary to popular opinion, is DID. Is it true that DID is not really having several personalities inside of the person, but it's rather it's having less than one complete personality that kind of just become fragments?
That fragmentation.
It's almost like, it seems counterintuitive, right? We think, well, of course, you have 6 people living inside your head, but they say no, that's actually one incomplete personality.
Right.
Okay, Bob.
Exactly.
Okay, Bob. Let Doc talk, Bob. No.
That is exactly, that's one of the theories. There's actually a lot more theories about it than true knowledge. What we do know is that basically there's a massive association with early childhood trauma. The trauma is usually sexual and or physical. And this is a sort of an altered consciousness that develops in the person that then takes over and allows that patient to sort of live in the midst of this trauma, and you're right. It'll allow, sometimes it's different identities. I've got patients, they'll tell me like, yeah, they'll have names. They'll have different names like Bob or Joe, and sometimes they're really creative kind of imaginary names, and they'll give me the personalities. Yep, exactly. They'll say, well, this person, this is my angry person. This is the rage person. And then sometimes this person comes out and this is the compassionate person, sometimes this person comes out who's like, the sexually hyperactive person, and so they live in this little world of changed perception. A lot of times memory is altered, emotions, body representations, motor control sometimes too, where they walk different and talk different and so forth, like all those pieces can come together in different combinations. So people always say, well, there's so many different combinations that go together that you can't put one finger on it. That's why it gets missed a lot, right? Because people aren't paying attention to it. And we don't, as providers, oftentimes have the luxury of seeing them switch right in front of us, like we don't see that oftentimes. So unless the patient reports it or a loved one reports it or a counselor reports, because counselors spend a lot more time with them than we do, then sometimes it'll go undiagnosed. And so you look at people and you say, well, if there's PTSD and there's depression and there's substance abuse and there's somatoform disorders and sometimes non-epileptic seizures like pseudo seizures where they look like they're having seizures, but, it keeps coming up negative on the EEG and the neurologists are like, these are not real seizures, and you have to make sure to not discredit patients' symptoms, but conversion disorders, we'll see that a lot. And when that happens, you got to start digging, and you got to dig gently and carefully because these folks won't necessarily just open up and be like, oh, yeah, it's because I got abused when I was 5 years old. Like, that's not going to happen, No. But the outcome is not just different identities and different memory capabilities and so forth. It's oftentimes self-treatment, because it's a very uncomfortable zone to be in. And sometimes they'll say, oh yeah, this is the personality, this one here, this one smokes weed all day long, and so they'll use the chemicals. Again, it's unfortunately all retro, right? It's all in the past. It's not preventive. How do you prevent a 6-year-old from getting abused? Ooh, that's a hard one,
I was abused. I was
right.
Yeah, at 6.
Right.
But you know what? My mother, I didn't remember until maybe 10 years ago because my mother made sure I forgot about it.
Yeah. And when you say she made sure, like what did she do?
Well, okay, so the boys behind us, 18-year-old boys behind us, my sister, my best friend, and I were in the backyard playing kickball, and they got us in their shed with candy. And then they sent us home, and it was Sunday dinner, and Mom said, what did you guys do today? And we said, oh, we went over to the boys' house in the shed. And the next thing I saw my 3 older brothers stand up and leave the table. And then they came back about a half an hour later. And my mom said, well, girls, just don't ever do that again. And then, she just never said another thing about it. And I didn't find out. And then I remembered, like, my husband I never seen him bring this candy in the house. And he bought those dots with sugars on them, the dot candy with sugars.
Yeah.
And he put them in a bowl. And I said, get those out of the house. And he looked at me, he's like, why? And it came back to me. That's, And so, but I was like, I had to call my sister and she said, oh yeah, because Mom didn't make a big deal about it. And I found out that my brothers beat the crap out of the guys. And then the family behind us moved. But I never knew any of that until I was You
never knew.
No.
And that's very, very common. No. And so the big question really becomes, how do I treat that? That's one story. Different medications, therapies, EMDR, blah, 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 blah. More interestingly, how do we nip this earlier? Obviously, that generation of parents, it was basically,
there was no psychiatry.
So no. So silence and shut it up is the way to treat it. If you don't talk about it, it doesn't exist. That was the mode. Yeah. And you're right. it'll show up, decades later, and maybe a trigger. And I do see that a lot where people come in with a trigger.
Honest God, Doc, I mean, it's like a nothing burger to me. It's really like a nothing burger to me. I don't have, I mean, of course, we all have trauma from our childhood. Show me one person that does not have trauma from their childhood.
Right.
And I'll give, even my children do. And I try to be the best mother in the world. But sometimes you just don't know what you're doing. Like teasing children is the worst thing in the world you can do because they don't understand that. And I used to tease my children a lot.
Yeah. Now, do you think that as a child, that dissociation from the trauma in your infancy sort of childhood brain was a defense mechanism? The amnesia was a defense mechanism that your brain chose? Because clearly there wasn't any help around to help you process it, Was it a natural, not a healthy, but was it an understandable mechanism your brain chose to use to get you through this?
I have no idea, but
almost protective, almost like your brain was trying to protect you. Like, let's make her forget this. Like, and maybe when she's older, she'll be more mature and be able to deal with it. I truly think it was.
Because I credit my mother. I really do. She was, I mean, she just didn't forget about it, don't ever do that again. And then we weren't allowed to go,
Right.
I don't know.
But that's a protective mechanism that
I never thought I'd tell that story, but here I am.
Right. Maybe your brain thought to itself, well, this is how I'm going to protect Rini from this. And maybe we'll never have to address it. Oops, the dots came into the house. I guess we'll have to address it now, So
I did go to therapy. I will admit I did. Right. But I think every adult should go to therapy.
Right. But look how, was it luck or fortune that you were able to process and get through that and come out the other end okay? Because clearly not everybody does. Some kids like you, they may not have had that supportive environment when the trigger hits. And maybe it wasn't the trigger like Candy when you were as an adult and more able to process. Maybe it would have been at age 16 or 20 where the immaturity still takes over. And then those people grab weed.
Different. Yeah, completely. Yeah. Completely different. I agree 100% with that.
Right. And that's always the sad part.
I'm sorry, go ahead.
I mean, I think my brain protected me in my teens and young adults ages of not getting in a circumstance where I could have something happen.
Right. Exactly.
I'm sorry, Neil.
No,
I promised Neil yesterday that he could talk.
This is great. You talk about preventing from early on, right? Catching certain things early on. So because you said most of the things are just, it's always a afterthought, okay, after it's happened, we think about all this. Are there signs for dissociation in kids that we can look for? Are there any signs that, we could be aware of, or is it one of those things that it flies under the radar?
That's a hard one. Can we, when you say we as parents, if there's parents, especially if there's parents that are involved in the abuse, no, of course not, because they don't want to see that, and that's not in line with what they want. Yeah. Can other people, can teachers be taught to look for things like altered states of consciousness, memory loss, when they see children in school drawing pictures of different characters that might represent alters, they might click down and kind of ask some more questions like, who is this and what does this represent? But teachers, that's not their job, right? That's where, teachers might better be able to come up with, at least screen and see some of the warning signs like depression or odd behavior, that they can then alert the psychologist that can then kind of click down and take some of that information and run with it a little bit, look at it, and maybe it's a false alarm, maybe it's not, but the fact that there is so much other stuff that goes on, teachers can see some of the things in school. Obviously, loved ones and family, if they're not involved in the abuse, can pick up on things, especially somatoform conditions where they have unexplained body pain, conversion disorders, school avoidance, and then because oftentimes these kids will develop personality disorders. Remember, personality disorders come after the trauma. They'll trigger like borderline personality disorder. Parents can't recognize; they're not trained to recognize that. Conversion syndrome and stuff. Avoidant personality disorders. Those are all adaptations to chronic trauma, but they're really hard to pick up on because they're not. Number one, parents aren't looking for it because they don't really know how to look for it. And number two, they don't want to look for it because the whole denial thing, we don't want to admit there's a problem in our kid. That's why it's so important that we have some kind of an outside force that's constantly nosing around in their business, tactfully building a relationship in middle school, first day of middle school, and then slowly building a rapport with that kid where the kid feels safe, like this is a safe zone to talk about, hey, your teacher showed me some pictures that you drew. It's interesting stuff. Give me some detail on what's going on here, that might uncover, oh, that's Joni. She's the angry one. Well, let's have a little conversation about that, Does that represent something? Hey, do you sometimes feel like you're kind of walking around and you're floating above your body? Do you sometimes feel like, and they can ask these kind of non-judgmental, because it takes tact and caution. You can't confront a child. You have to gently invite them to discuss stuff. Once they're invited, I've had kids really excited, tell me about all these personalities, and they describe them down to what they're wearing and how they walk and their mannerisms, and sometimes even involved parents will be there, and the parents will understand that as well when you have supportive parents, But it is one of those where it's simply a zone to say, we have a lot of digging to do deep down to what happened, like there's a lot of work that needs to be done. And now that it's coming out, at least we understand that. And the consequence of it, that's the addiction. Patients sometimes call and ask me, they're like, we know you're an addiction doc, but do you just treat like, depression, anxiety too? And I'll say, that would be wonderful to treat that before it turns into the addiction. I'm like, I'm so happy with just depression, not depression and heroin, the less problems, the easier it is. But how is that not true for everything? Even better, I'd rather just not see the kid. I would rather have had a therapist get a hold of them in fifth grade and dealt with it right then and there.
That's what I did to my kid.
Never been confronted. And so why don't we do well checkups on children? Half the time,
mental health.
I don't even know why, right? But why are we doing a well child check? Oh, step on the scale. Are you growing? Are you eating your veggies? Here's your tetanus shot. That's not important. Anybody can do that, What's important is spend the time with the well child visit and talk about the kid on how life is going. Where are they at? What's frustrating them? On the background, you can order your tetanus shot and do all the other stuff, but spend your time investigating. So I work with the pediatricians a lot around town here, and I'll tell them, hey, anytime you get a sense or a hint or you're worried about something, just call me up and we'll shoot the breeze about a patient and kind of see if something requires a little more investigating, and maybe it's just a warning, maybe it's not, maybe we'll keep our eye on it, but let's bounce it around. Doesn't hurt, right? If it's a false alarm, good, it'll resolve and nothing will come of it. But I'm glad you picked up on it, because you don't look, you don't find, but that's the same with all preventive stuff. Why are we not looking? We looked for breast cancer. Oh, women, please do your monthly breast checks. Guys, please check your testicles every month. Please do PSA blood tests. Please get your mammograms. Like, we do so much of that, and yet we completely forget that the brain is kind of an important organ, Oh,
especially in a child.
Especially in a child. do me a favor. Preventively talk to the parents of kids they're going to. Preventively go snoop around in their phone. By the way, there is no privacy when you're a child in the family. It's a dictatorship. Okay, get used to it. It's your job to snoop in their phone. It's your job to snoop in their urine too. You can do that. You can snoop in anything. That's what a dictatorship's all about. You know, you want to drive a car? You drop a random urine test. I don't care if they're always negative. You know, it's my choice, my keys, my car.
Right.
My house, my castle, you know.
I still pay insurance on my kids' cars.
There you go. Right.
And they're
absolutely. Right. Right.
So,
but that's where
Doc,
the preventive comes from. Yeah.
Doc, one question. How much longer do we have you for? Because I don't want you to miss your
10 minutes.
Okay.
10 minutes.
Let us know because I don't want you to miss.
But then I'd love to. I do want to
test.
keep this conversation going. I want to join you guys again sometime because this needs to go on. You know?
I want to talk a lot. I love this talk about the child brain because I wish there was a handbook.
And there was one question I had related to that I really, and maybe this can be the final one for this particular, and we'll have you back on in the future. But, you know, one of the things you talked about, you know, seeing signs and all that and checking people's phones, because your area of expertise and other addiction specialists, I'm sure, a lot of focus is on the tangible addictions, right? Alcohol, drugs, stuff that physically goes into your body and changes your brain. So can an intangible stuff like an addiction to social media ever become as hazardous as that? And it's like, I guess it's like a two-part is, B, do we need centers just for that, just for social media, online gambling, like we do for alcohol centers and drugs? So,
great question.
Yes. And the first treatment center is called the home. And if you don't have that treatment center in place, you're hosed. And here's the, now we'll talk about this next time, but you can Google the words TikTok related tic disorders. So I've seen a couple of adolescents with tic disorders triggered by mannerisms.
I'm horrified.
TikTok. So now the I think Yale and Stanford have published some papers on the discovery of these disorders, especially movement disorders induced by social. Of course, we always have known and nobody can argue this, that social media induced body dysmorphic syndrome, right? Like, come on, you can't argue that, right? Now we have tic disorders. I told my med student, I said, look, I grew up with depression and anxiety and bipolar, and we have schizophrenia and all these cool things. Here's a new disorder that's going to be new to your generation. It's called social media mental health disorders. We're going to come up with all sorts of cool different names for it, but it's going to come down to this. Social media, taken again in the age when the brain is malleable and vulnerable, is going to lead to massive problems, right? And sure enough, it does. Facebook has admitted to that.
Doing it.
They're doing it. They've admitted to it. And you can see it as plain as when I have a girl come in who brings me a list of her first 6 most important surgeries, plastic surgeries, and she's like 10 or 12, and she's like, I know these are the right surgeries. I need you to help me figure out which one I should do first. Like, she's that serious about it. She needs a hug. She thinks I'm going to help her figure out whether her nose or her ears need to be done first, you know? Like, she has no insight, and the social media drives that. And so it will be a crisis. I know we have the opioid crisis, but this will be a socially accepted crisis because social media is socially accepted. We will condone this crisis until, I don't know, it really hits the fan. Tons of people get affected from it, you know?
Well,
and
do
then
you
we
think
will
realize suicide, there have been suicides because of social media, and yet that doesn't seem to, I mean, people talk about it, but they don't do anything about that at the end of the day. So no, exactly. And at the end of the day, we're like, oh, what a bummer, man. I guess they were just, you know, too vulnerable. Well, guess what? You're giving the phone to your child. You're paying for it. You're responsible for whatever consequences come from that phone. You don't just hand your kid a car key. You don't hand your kid dangerous items and then wonder, like, look at the latest school shooting, complete access to a weapon.
No, you mix young age, immaturity, impulsivity with something dangerous, a gun, social media. Of course, we don't think it, oh, guns are more dangerous. No, no, they're all equally dangerous in different fronts, alcohol, substances, automobiles, I mean, it's not a good recipe. And if you enable that by allowing that kind of social media, and I think more and more it's becoming proven that that is the case. This is no longer like, I wonder if social media causes body dysmorphia in girls. Like, no, I'm pretty sure that's that's been established 100 billion%,
Kim Kardashian.
Right, exactly. And yet we feed it, we live it, whether we're watching it on YouTube or the TV. We crave that kind of self-destruction. And then when we recognize it, we're like, us who? We're not doing it. We're in complete denial about having fostered and enabled that behavior right from the get-go, right?
And do you think that do you think that social media addiction will curb is not the right act. Do you think that it will stop kids from getting addicted to maybe opioids? Or is it just
I think it's a different kind of source. And when we say, hey, what triggers opioid addiction? A lot of times it's the lack of proper treatment for a mental disorder. So, is social media a proper treatment for a mental disorder? No, I don't think so. So I don't think it's going to curb it at all. If anything, I think it's going to perpetuate it because it's a numbing agent, right? Social media, they're staring at it, flipping through it, they're numbed out. And by looking at social media, they don't have to address the underlying problem, right? It's a numbing agent. That's like saying, is any numbing agent a detriment to treating social media? Of course it is. Is alcohol a detriment? Well, it numbs you out. Eating Oreo cookies, is that a detriment? Yeah, because then you're just numbing yourself out with Oreo cookies, So it becomes a detriment in as much as it enables the person to not deal with the problem they're supposed to deal with, right? Yeah.
Therapy.
Yeah. It's tough.
Yoga,
it all boils down. It all boils down to that.
What is that? What is that behind me? Is that the sun?
That's the sun.
You guys see that?
Yep.
Is that the sun?
Yep.
I'm like,
that's the sun.
Let's see. Okay. I was like, boom, what is that?
You guys are awesome. I'd love to
awesome.
keep talking. I'd love to keep talking,
guys.
I hope this was somewhat valuable,
It was
very much so. Very, very much so. Yeah.
It was. It truly was.
There is such a breadth of this, and as much as I love my work, I still always wonder why
you want to be bored
retrospectively. I want to be bored. I wish these kids would have gotten nabbed earlier. I wish this person would have come in before the weed set in. I wish this person would have come in when it was only weed and not weed plus alcohol plus heroin. I wish this person would have showed up before they were dead. It goes all directions.
Well,
then we do treatment,
You were the man, so I want you to be bored, and I want there to be a handbook, not what to expect when you're expecting, how to raise a child,
how about
when your brain is malleable.
How about what to expect when you're totally not expecting it?
I know, right? That's a good one.
Perfect.
Okay, Doug,
that'd be a good one.
You have a wonderful trip, and Merry Christmas and Happy New Year.
Too. Absolutely.
And
to your mother as well.
Yeah, that's what to your mom. Yeah, I hope
I will.
I hope she's okay. And
she'll do wonderful.
We're booking you after you get back. Okay.
Promise. We'll keep in touch. Thanks, guys.
Okay.
All right.
Take care, Doc.
Appreciate you guys.
Bye.
Bye.
Thank you.
Thank you, Doc. We'd like to thank Dr. Edrich for joining us today, and you can find his information in the description below.
Be sure to follow us on Facebook, Instagram, and Twitter at all the links listed in the description. And make sure to subscribe to this channel so you never miss an episode. Thank you, everyone, once again for joining us, and we will see you right here next week, 9 a.m. Pacific time.
Thank you. Bye-bye.
Thank you.